in 10 minutes, like only a New Yorker could do, speaking very quickly. But let's see. So, the roles are, like in many other solid tumors, detection, characterization, staging, and assessing response to therapy. Unlike many other tumors, all of our imaging modalities actually play a role in prostate cancer. Ultrasound, CT, MRI, and PET, and increasingly, I would say it's MRI and PET. So what I thought I'd start off with is just showing in the detection, characterization, staging, and assessing response, kind of what people are doing in terms of state-of-the-art. There are many, many options that are available, but certainly you're familiar now, and I think most men ask for the combined MRI ultrasound fusion, and this is an actual physical device. Some people do fusion in their minds and consider that to be a technique, but this technique is actually quite good. The JAMA article in 2015 noted that more significant prostate cancers were able to be diagnosed at biopsy using the MRI ultrasound fusion technology. In terms of characterization, I think that we're entering a whole realm, and it's very similar in many of the technologies that we actually heard about yesterday in renal cell. For instance, here, a very small series from the MR literature looking at two different types of diffusion techniques. Diffusion-weighted imaging provides information about the functional environment of water in tissues. Detected changes include shifts in water from the extracellular to intracellular space, restriction of cell membrane permeability, increased cellular density, destruction of cell membrane, depolarization. Two of these relatively new techniques are the measurement of mean diffusivity. And in this study, the group was actually, even with a small series, was actually able to distinguish between Gleason 7, 3+4, and Gleason 7, 4+3. So, potentially impressive. Obviously, this needs to be validated in much larger multi-center series. Staging, well, we could look at MR, we could look at all the different PET technologies. I'm saving some of that for one or two other slides. So, as we heard yesterday, a 6-minute sequence that will and should replace the bone scan and should as well replace evaluation with CT for soft tissue disease. Combined whole body and dedicated prostate magnetic resonance imaging is feasible in a clinical practice setting. It can provide incremental information compared to standard imaging in men with suspected prostate cancer recurrence after radical prostatectomy. Lastly, in terms of assessing response, I think this is where the prostate community and many of you here have actually made the greatest progress. It's in creating a platform. The Prostate Cancer Working Group 3 criteria and the standardized forms are really able to move drug development closer to unmet needs. Yesterday, Oliver presented a lot of great information about clinical trial endpoints and response, and he talked, and I think the comment you made about RESIST was, we hold it up, to be an important standard, not quite sure why. Well, there's actually good reason for that, and I don't know how many of you know this story, but does anybody know what the first use of RESIST was as a biomarker in the medical literature? And it was in the European literature. Anybody know this story? Well, I'll give you a hint. It appeared in 1835.
It had to be in the Lancet. That was like the only journal at the time.
You're close. Now let me tell you.
British Medical Journal, B&J was there.
Okay, now let me tell you the author.
First and last.
Only author. Sole author paper. And what am I talking about? The Princess and the Pea. And that was the first use of a biomarker. What was the biomarker here? The P. The P was the biomarker. Do you know where I'm going with this? You don't know the story?
No.
Okay. How did RESIST and the original WHO come into being? It was an experiment that Mortel did in his hotel room at ASCO in 1976. That was when clinical trials were starting. And what he did was he placed spherical balls underneath his mattress, and he invited 16 of his oncology friends back to his hotel room, and they palpated these pairs of masses. And only when the masses were a difference of 50%, those of you who are old enough remember the WHO criteria of 50%, that's why we have a definition of a partial response of 50%, and that's why SWOG created a progressive disease of 50%, because in 1976, you did response assessment by physical palpation. The 50% in WHO was changed to 30% just mathematically in RESIST, and that is our definition of partial response. This isn't a joke. This is serious. So, we should hold it to good standing because, it first appeared in 1835. No, the point of this is that there's actually no biologic relevance to the RESIST criteria. And certainly, twofold. A, no biologic relevance to RESIST criteria, and B, in RESIST 1.0 and in RESIST 1.1, there was 0 prostate cancer patients there. So there's clearly not any relevance. I mean, it is a standardization technique, but you guys have already surpassed that with Prostate Cancer Working Group. So really forgetting about the goals and forgetting about the modalities that we have, I think here's the key: to incorporate imaging into clinical trials to better assess novel therapeutics and ultimately improve patient care. So we've heard a lot, and I'll just touch on 1 or 2 topics. Multiparametric MRI, it sounds great. What is it actually? We've been doing multiparametric MRI for a long, long time, even before the term was around, but it's basically anatomic, high-resolution, soft tissue imaging with T2, diffusion-weighted imaging with looks at the movement of water molecules, dynamic contrast-enhanced imaging, revealing a tumor's blood flow, and spectroscopy to give metabolic information. You combine that, and you have a multiparametric MRI. The other nice thing about MRI, and the other part of this platform, it's probably slightly less important in advanced metastatic disease, but is in PIRADS reporting. And this has caught on really nicely. It's a highly reproducible technique that's now used by radiologists throughout the country. PIRADS 1 being very low, clinically significant cancer is highly unlikely, to PIRADS 5, very high clinically significant cancer is highly likely to be present. In terms of PET agents, hopefully we'll have a chance through the day as we discuss trials and other techniques to look. I think, the days of FDG are gone. Increasingly, we're looking to the PSMA ligands, and certainly in the United States when those are easier to obtain and improve. Sodium fluoride, bone metastases only, potentially plays some role, and of course, fluciclovine and the choline agents. So Prostate Cancer Working Group put together this methodology, and it's simple yet really elegant for a number of different reasons. It could be used in multi-center trials. We have a high rate of reproducibility and repeatability. Chuck has shown this in his studies as well. And here, this is the enzalutamide trial where the independent review and the site review is overlaid on each other, and the results really are tremendous because they're identical, recognizing the FDA to recommend radiographic PFS replaced PSA as an interim endpoint. So now how do you add these other agents in? And I think the technique to do that is really to use this platform that exists. I think it was alluded to yesterday. We'll clearly have these imaging modalities, many of them being more sensitive. So the 2+2 rule may be a 3+3 rule. It may be a 4+4 rule. It may actually be a 1+1 rule. It depends how sensitive and specific we want to be. But again, we have the potential, using this as a platform, to do just these tests. So in summary, quantitative molecular imaging does provide a platform for linking many of the traits that we heard about, both in the renal cell talk and in the prostate talks, with specific gene expression patterns. And here would be my pitch that if we do more imaging in early phase drug discovery in terms of both quantity and complexity, and we learn and we understand that there, we could potentially decrease the use of imaging as we go across the drug discovery process and ultimately into patient care. So let's over-image here so that we could hopefully decrease the use of unnecessary imaging here. And then finally, just to remember, and this is the plea, the pitch, to incorporate imaging into clinical trials to better assess novel therapies and ultimately patient care. Thank you.
Larry, great talk. And I think really there's been so much progress in imaging over the last couple of years. But one of the things I'm concerned about is the lag in being able to make a therapeutic plan based upon what we're seeing. We're picking up disease earlier. And for example, I had a patient that I saw recently who had a positive flucically PET scan. We saw in lymph nodes. And then the issue is, how do we treat this patient? Do they go on maximum hormone therapy? Do they go on abiraterone plus hormone therapy? And chemotherapy is not an option. But the problem is that detecting disease earlier, now we have to readjust our therapeutic algorithms. So with these particular scans, what's being done to either on a registry basis or otherwise to track how people are treating these patients? Because clearly you can't do a randomized trial. It's almost impossible. So how are we trying to correlate the therapeutic endpoint with the imaging endpoint?
So actually very little is being done. Really that's our challenge and that's our problem. I wouldn't say that you have to randomize the patients, but I would think that we should try early on to correlate our existing imaging modalities with the newer imaging modalities just to understand them a little bit better, but then also track and follow therapeutic changes over time with the newer techniques, especially with the PET tracers.
So you really need a registry to do that. That's the only way to do it as
Well, yeah, you could do it on a registry. Registries are, tough. They're sometimes, especially imaging registries, are very, very dirty. I would say the use of clinical trials as the registry would really be the optimal, approach. And in the end, I think it would actually save a tremendous amount of unnecessary scanning.
So yeah, I have a comment. I think we have to be cautious about using some of these new traces as a reference standard for disease. We don't have a lot of data with histologic confirmation, and those groups that are actually doing a lot of biopsies in these lesions, you actually get other things than metastases that show up on a gallium PSMA scan, like fibrous dysplasia and things of other benign disease that can occur in the bone. So just a word of caution in
Yeah, I've had false positives
Yeah.
on PSMA PET from lymph nodes or some follicular proliferation, lymphoid proliferation of some kind. And I don't think we have the discipline in this country to do a randomized trial of PSMA PET guided therapy. What we should do is do a randomized trial of PSMA PET driven treatment of oligometastatic disease versus hormones versus radiation or something like that. See if we can cure some people who are otherwise going to be put into the incurable metastatic bin. But I just don't see the possibility of randomizing people. I think the equipoise window is closing.
Right.
Yeah.
No, I agree. That's the challenge.
Good point. We're going to need to move on.